You're listening to a podcast of the World Stroke Academy, the educational platform of the World Stroke Organization. Future Stroke Leaders is an initiative of the WSO to develop the technical and research skills of the next generation of stroke professionals. The World Stroke Academy welcomed the contribution of the Future Stroke Leaders members by inviting them to cover specific stroke-related topics in our Pearls podcast initiative. Today's topic is Cerebral Venous Thrombosis, presented by Miguel Barboza.
Thank you very much for this opportunity to share such an interesting topic as PERS in the diagnosis and treatment of cerebral venous thrombosis. My name is Miguel Barboza. I work as a stroke neurologist at the Hospital Dr. Rafael Calderón Guardia in San Jose, Costa Rica. Also, I serve as assistant professor at the School of Medicine in the University of Costa Rica, and I'm part of the WSO Future Stroke Leaders program. It's a great pleasure to share with you this short podcast in this interesting topic. First, why speaking of CVT? Well, despite it's considered as an uncommon cerebrovascular condition, the onset clinical picture can be challenging, and early recognition of symptoms and emerging features could lead to better functional outcomes. Also, this is a condition that usually is present early in life, usually less than 4 years old. Therefore, in terms of disability and socioeconomic impact of the disease in active working population, it's important to be recognized. One of the main pitfalls in this cerebrovascular condition is the delay in the diagnosis if not suspected at the emergency department, especially when subtle changes in the plain CT are not recognized, to ask for further studies. CVT, as previously mentioned, is less common than usual arterial strokes, goes from 0.5 to 1% of cerebrovascular syndromes, with a higher incidence in low and middle income countries as reported from tertiary stroke centers in regions like India, Pakistan, Turkey, or Mexico. It's more frequent in women with an average of 30 to 35 years old for the index CVT, where functional outcomes are better, compared to CVT in elderly patients where association with neoplastic conditions could be more frequent and mortality and bad functional outcomes too. In terms of association and etiology conditions, two types of CVT have been proposed. One, related to precipitant transitory factors, such as pregnancy, puerperium, oral contraceptives, replacement hormone therapy, or parameningeal infections. Or two, those related to predisposing factors, such as genetic conditions. We can name the 5 Leading Factor mutation, protein C or S deficiency, for example, or acquired thrombophilic conditions such as antiphospholipid syndrome or erythematosus systemic lupus, most of them presenting in the first, third, or fourth decade of life. Diagnosis of CVT can be challenging, as this could be a mimic of other diseases, especially when presenting with isolated signs and symptoms. Most of cases present in an acute phase, from 7 to 15 days, with typical symptoms that could be grouped into isolated intracranial hypertension syndrome, focal syndrome, including seizures, motor, language, or sensitive impairment, and encephalopathy that goes from decreased consciousness until coma. When analyzing individual presenting symptoms, the combination of headache in 80 to 90% of cases, seizures, and focal deficit is one of the most common clinical pictures. Pathophysiological explanation of these symptoms come from the radiological association found in so many cases, where the pressure of the thrombus load leads to increased cortical vein pressure, with subsequent edema that leads to venous infarction, or cortical veins rupture that leads to hemorrhagic venous infarction, especially in those anatomic regions where the number of cortical veins and collateral venous system is more relevant, such as the superior sagittal sinus and transverse sinus. In 1/4 of cases, direct plain CT can demonstrate direct signs of CVT, such as dense triangle sign, which means that there is a clot in the superior sagittal sinus, the empty delta sign, which means that there is a non-opacified thrombus surrounded by the vein walls after injection of contrast, or an increase in attenuation of the occluded sinuses. Magnetic resonance venography, NGCT, or digital subtraction angiography are the main standard studies to demonstrate the clot presence. Biologic markers such as D-dimer is a potentially useful diagnostic tool, but false negatives could happen in cases with isolated intracranial hypertension or symptoms with a time window of more than 15 days. Functional outcomes in CVT are usually good, with modified ranking scores less than 1 in more than 80 to 85% of cases, with a mortality rate from 0 to 2%. Some scores to predict acute functional outcomes have established that the size of the parenchymal lesion, including hemorrhagic infarctions, bilateral pyramidal involvement, male sex, and decrease in consciousness could be variables related to bad functional outcomes. Therapeutic approaches have been studied in case series and in few randomized clinical trials due to the difficulty to achieve a big sample size to prove efficacy with the current standard medications. The European Stroke Organization and the European Academy of Neurology presented at the Cvt Comprehensive Guidelines those recommendations with a higher level of evidence for pharmacological management. For example, there is a trend in the evidence that low molecular weight heparin in acute admitted cases is the preferred first approach as anticoagulation therapy. But for long-term anticoagulation, vitamin K antagonists remain as the gold standard with median duration of oral anticoagulation of 3 to 12 months, depending if the etiology is related to a precipitant transitory factor, in which case the short-term oral anticoagulation regime is preferred. For those cases with acquired or genetic thrombophilic conditions, long-term therapy should be recommended. In terms of direct oral anticoagulants, the guidelines present weak evidence for their use, mainly extracted from some case series and one single randomized open-label multicenter trial exploring dabigatran versus warfarin in a small sample size of 120 CVT cases, finding that both therapies present with low risk for thrombotic events, intra or extracranial, and the risk of bleeding was similar for both medications. Despite this, no changes in therapeutic approaches have been made in terms of guidelines and standard of care. Endovascular acute therapy of CVT remains as unproven therapy, with low quality of available evidence. Also, thrombolysis, analyzed in the randomized controlled trial of thrombolysis or anticoagulation for severe acute CVT to ACT, was terminated prematurely for futility. In those cases presenting with severe CVT related to intracranial hypertension, large parenchymal lesions, and impending herniation, the guideline recommends as a strong evidence to consider the compressive surgery as a saving measure. In conclusion, despite its low frequency, recognition of CVT in the acute phase is important to increase its good functional prognosis, mainly due to the clinical syndromes presenting according to the location of parenchymal lesions. Also, remember that low molecular weight heparin in the acute phase and vitamin K antagonists in the long term from 3 to 12 months are the gold standard therapeutic approaches. Now, some pairs for Cvt management approach: when to suspect, who is the population at risk, how to make a diagnosis, and avoiding pitfalls. 1. When facing severe sudden headache in high-risk population for CVT, such as young women on oral contraceptives, childbearing women, postpartum, or abortion, think in CVT as a differential diagnosis. 2. Similarly, a clinical presentation of headaches or a focal neurological syndrome, seizures, motor, and sensitive or language deficit in this population should raise your suspicion for CVT. 3. When suspecting CVT, order a venogram study, angio-CT or angio-MRI, as soon as possible, or directly from the emergency department to determine the patency of the cerebral venous system. 4. Call for a neurology and hematology on call if CVT is confirmed, or imagine raised concerns to start the optimal treatment. 5. Anticoagulation therapy remains the main treatment for CVT. And 6, the compressive hemicraniectomy and endovascular removal of the thrombus are therapeutic alternatives for patients with progressive neurological deterioration or for those who fail medical treatment. Thank you very much.
Thank you for listening to this podcast. You can find additional stroke education material and resources in our World Stroke Academy website and social media channels.